Welcome all tonight in the UK, and it's an afternoon, I think, in the US, most of the US. So this is our fourth ISBNPA webinar, the Children and Families webinar, considerations and challenges in conducting research in children and families. Diana Hulscher is moderator, and Ron Iannotti and Suzanne Phelan are going to present some slides. So I'm Rick Prince, and I'm going to give a very short introduction and housekeeping notes about the webinars. So we are very delighted that ISBNPA can actually give those fantastic webinars to a broad audience. And those webinars are organized by the special interest groups that our society is rich, which you can find on our website www.isbnpa.org. So there are 8 special interest groups at the moment, and please look at our website to see whether you want to join one and whether you can contribute to one. So we are organizing 6 webinars in last week and this week, which are all in the events tab of our website as well. So there may be another webinar which you are interested in. For instance, in a couple of hours there will also be the webinar on early care and education, which you can see over here. So there are still some places left for that webinar, so you can still sign up for that one as well. So we are using the GoToWebinar system, and it's a very straightforward and easy system to use, but just a few issues that we came across when testing it. So you may all see that you're muted. So we do that to avoid a lot of noise going around. But we do value your feedback, and we do want some interactivity during the webinar. So if you do have questions, you can type them in this question box in the system. So in the enter a question for staff box, and you can do that during the webinar already. So at the end, Diane will ask questions that come through this system and mention your name as well. Another thing, if you really want to enjoy this webinar at its full capacity, we recommend you using the full screen mode by clicking on that button. So that is it for me for now. So I will hand over to Diane for her presentation.
Okay, thank you, and thank you all for being here for this presentation. As Rick said, this is considerations and challenges in conducting research in children and families. So today we'll hear from experts in what you can do to recruit families and what are some of the thoughts that you need to have to prepare for research with children and their families. So today's webinar will include 2 speakers, Ron Iannotti from CDN Group in Bethesda, Maryland in the USA, and Suzanne Phelan from California Polytechnic State University from San Luis Obispo in California at USDA. And then I'll be the moderator, and I am Deanna Hulscher from the Michael and Susan Dell Center for Healthy Living at the University of Texas School of Public Health. I'd also like to acknowledge Leah Lipsky, who helped organize this webinar.
Deanna, can I just, sorry to interrupt you, can you try to have your slides on? I don't think you are sharing your screen.
Oh.
Okay.
There.
Yeah.
Okay. So let me just go back a little bit so you can kind of see what all our speakers look like. So the agenda for today is I'm giving a 5-minute introduction, and we will be followed by 2 presentations. Ron Iannotti will talk about school-based research, and then Suzanne will talk about challenges of clinical trial research during pregnancy. So each of these presentations will be roughly 20 minutes, and then there will be a question and answer period. And then we'll follow up with a slight wrap-up with information on how to contact the presenters, as well as information about where the webinar will be archived. And so with this, I'd like to turn it over to Dr. Iannotti to begin his presentation.
Thank you, Deanna. So I'm going to be talking about school-based research and covering mainly recommendations on things that you need to consider when you're trying to work with children in a school setting. Some of you probably have a lot of experience. I'm hoping at the end you'll give your own stories about what worked and what didn't. And generally, we're going to be really interested in hearing your questions.
Can I, sorry, it's again Antonio. Can you please share your screen if you have presentation?
It's open.
Also? It's open?
Yeah. Is there something I need to do?
You should share your screen.
Okay. Let's see.
Go ahead and share.
Ah. Did that do it?
Yep. Now it's on. Thanks.
Okay. And so the first question is, why do school-based research? There's a fairly well-known bank robber in the U.S. called Willie Sutton. And when reporters asked him, why do you rob banks? He said, because that's where the money is. And the same is true with children. They spend most of their day, or a good part of their day, in school. And so school is a good setting for recruiting children, for working with kids, and actually for approaching their parents as well. So even if you're doing family-based research, you might start in the school, particularly if you're interested in a particular age group of children. The setting is familiar to children, and many schools have the facilities and staffing to assist you with research, although that's not necessarily a given. Most schools are very busy, their staff is busy, the teachers are busy, and so you need to be cautious in assuming that you'll be able to get space in the school and that they may assist you in actually conducting the study or in recruiting the children. Even the assumption that schools are interested in health is not necessarily the case. You may need to convince them that there's a relationship between your study of health, so like physical activity and school performance and diet as well, and how your health intervention may improve attendance, which could then obviously have a relationship to academic performance. And then there are a number of challenges for working with schools. There's a variety of administrative hurdles, and we'll talk about those in a second. But also with schools, there'll be absentees. Students may not show up on the day that you're conducting your survey or you're intervening. And so you should include plans for either following up on the absentees, either with a follow-up survey or a web-based survey, or considering how you will address the issue of absentees. And in addition, schools have dropouts. Some children are homeschooled, and then there are chronic truants. And the absentees, dropouts, and the chronic truants are likely to be the participants you may be most interested in because they tend to are more likely to engage in high-risk behaviors. And then schools may simply refuse to participate for a variety of reasons. Sometimes schools will refuse to include your study if it has a particular set of questions or issues that they don't want to deal with. In my own experience with the Health Behavior in School-Age Children study, which is conducted in the US, Canada, and about 40 other countries, mainly European countries, we're the only country, the US is the only country that is not asking children about their sexual behaviors. Some schools would permit that, some schools wouldn't, and if we want to get a representative sample, we had to adjust our survey. The other thing of concern, particularly in the U.S., is the heavy emphasis on standardized testing, and schools are very cautious about having any kind of intervention or study conducted in the school that might interfere with their need to teach the children about standardized testing, because that is one of the ways the schools are being evaluated. So generally, many of the recommendations that I'm going to suggest will depend on your setting. Depend on whether you have funding, in which case that's great. You'll be able to do things like provide incentives that others might not, but also depends on whether it's a local study, a regional study, or a national study. Local studies will require much more hands-on interactions, particularly if you're in a university town where the schools have been inundated with other researchers wanting to work with the kids. So the first step is to develop a plan. You should think about exactly what you're going to do, lay out your recruiting plan, make sure it's flexible, because you'll certainly hit some barriers and hurdles to go through. You should start recruiting schools like 6 to 12 months before the school academic calendar. Schools are more likely to let you come in if they have a lot of warning, and much like we will accept tasks if people tell us we can do them way in the future, and we don't think we'll be quite as busy as we are. Schools are the same way, and so approaching them in advance is really important. You also need to decide what you can give to the school. In some ways, you can try and build this into your research. I've been in studies where schools have indicated they have a particular question they want to answer, and so I will include that in the survey. Or they may have a program that they're developing, and you can offer to help develop the curriculum, present to the assemblies, or talk to the other groups related to the school. And so you should think about what you can give back to the school. Certainly you want to be able to provide them with final reports so that they can find out the results of your study. And you'll probably hear from schools that complain when researchers go into the school, do the work, and then essentially abandon them. And then finally, you want to be enthusiastic about your study. You want your staff to be enthusiastic about your study, and you want to convey that to the schools. If you're not, do not appear to be excited, they're wondering why they should be excited and let you in. Now, at the country level, if you're doing a study at the, it's not really, usually it's not that important to get endorsements from national institutes. What is important is to get endorsements from professional organizations that are national or regional. That can be helpful. In some countries, I know that simply getting the country to agree to do the study almost instantly means you're going to have access to schools, access to the children. I'm always impressed with colleagues who, when I talk about response rates, they wonder what I'm talking about. And they said, of course we have 100%. In the US, I know that's not true, and I imagine that's not true in other countries as well. So first step is really recruiting the local school district. You got to remember that school superintendents are very busy, and yet the school, getting permission from the school district is usually just about essential. Although they are not the final gatekeeper, it's usually the individual school that decides whether you can work in the school or not. And there's two approaches: a passive consent approach, in which you are sort of proactively present the material, send the material to the school superintendent, who may not actually read this. He may give it to somebody else to look at. And you have all of your recruiting materials, your brochures, and if you are really effective, you can say, and these are the schools that were selected to participate. So the superintendent doesn't have to make that decision, and you may not want them to make that decision. It also makes them easier to approve. Some school districts will require much more active approval. They will have research committees, health committees that you'll have to apply to. If you have an application form, take those very seriously. Schools will, the committees will see any errors in your application as possibly reflecting the quality of your research. And don't be surprised that that procedure takes quite long, although it's hard to anticipate. We had one school district that we applied in April or March or April, It took a while for them to get to the research committee. The research committee was then dissolved. They started it up again during the summer, but the summer months people weren't really working. Then the director of the research committee left. And so we didn't get approval until February, January, February of the school year we intended to do the research. And so we never included that school district in the initial study. And so the other thing to consider is finding out from the school district whether consent for the children's participation can be active or passive. Passive consent is when you send home a notice to parents describing the study, provide them with all your other materials about the study, and they simply they will only respond if they do not want their child to participate. So non-response indicates that you've got consent. Active consent, you have to send a consent form to the parent, and they need to indicate and sign the form indicating they do want their child to participate, otherwise they're not participating. When you go to your IRB, you should probably try and get approval for passive consent if it's appropriate, but then get them to approve both an active and a passive consent form so you're ready to use either. Recruiting schools can be challenging. If it's a local school, you might want to try and get, and you have the resources to contact individuals in the community, you might try and identify community leaders and others, PTA presidents, Parent-Teacher Association presidents, those individuals, and see if you can get them to endorse the study. You also want to establish your credentials, and here, again, endorsements from health and educational professional organizations will be helpful. You usually think, and actually the principal is the one who makes the final decision, but really the usual gatekeeper in the school is the school secretary. So you want to approach them, be very nice, and provide the materials to them, and they may help coordinate your study. We found it useful to have a school liaison, an individual within the school who, in a sense, takes responsibility for helping you approach classrooms that you may want to conduct a study in, setting up space if you need it, making arrangements. So we conducted a study. We were measuring height, weight, and waist circumference. We had to find a room that gave students privacy and yet at the same time could process 30 or more students. And that school liaison was absolutely essential. So in this whole process, you need to consider that you have to be very clear about what you're going to do. You also need to find out about incentives. Some schools will not permit incentives, cash incentives, to teachers or certainly to students or to your school liaison, and you may need to work around that and find out what's permitted. You can also, and alternatively, provide something to the classrooms, teaching materials or a party, providing food, or something else that you can provide that isn't cash. And if you have a school incentive, again, if you have the funds to provide schools with incentives for their participation, because they do have to make a number of concessions if you're working in the school, you should probably arrange so that you provide half of the incentive once they agree to conduct the study, and then the other half once all the data has been gathered. I mentioned the importance of providing an in-school liaison. That really can make your study run much more smoothly. And you need to be very flexible about dates. It's usually not a good idea to ask to conduct the study in the first couple of weeks of the school academic year because schools are very busy getting started. And again, towards the end, they're really focusing on exams and tests. You need to also find out when they're conducting standardized testing because they will want time before that, and obviously during the standardized testing that they will not want any interruptions. I personally would also recommend you avoid days around holidays. Absenteeism goes up, the kids are really wired about the holiday, and they may be more other things that the school has planned, like parties and such, that would not make research really useful. When you're recruiting students, depending on the group that you're approaching, particularly if you're working with minority students, children with disabilities, you really need to consider your target population and develop your research strategy around that. You want to minimize the subject burden. And depending on how much you're asking the kids to do, you want to consider having incentives. Sometimes they can be fairly simple. When I was at Georgetown University in the medical school, we were conducting a study, and it was a time when Patrick Ewing was on the basketball team, and so we offered kids really inexpensive Georgetown T-shirts. And I didn't realize how important it was until we actually interviewed parents as well. And parents told me outright that they may not have participated, except their child just bugged them endlessly to sign the consent form because they really wanted that T-shirt. And so I don't think it was coercive. I didn't think it was coercive when we set up that incentive, but it seemed almost so. Another important thing to consider is getting back the consent form. So if you send the consent form home with the child, you should ask teachers what is the day of the week that they traditionally send things home with the child. Parents then know that that day they should check the child's backpack for the materials that the teacher has sent. If you can get the teacher to agree to send your materials as well, you have a higher probability that parents will actually see it. Probably any of you who have had kids know that sometimes a month later you'll find something in the bottom of their backpack and wonder, where did this come from? The other thing to do is to have incentives if the child brings back the consent form. And we actually we have this consent form set up so the parent can say yes or no, and then sign indicating in either case. And then we can provide incentives if the child provides a signed consent form. It's not, the incentive is not to get the parent to agree, but rather for the child to return the consent form. And usually the first few students that bring back the consent form, when the rest of the class sees the little incentive, they're more likely to remember, oh, that's right, I gave my mother or father or caretaker something to sign, and if I bring that back, I will get that incentive as well. So that can actually be pretty effective. We've had great success with that approach. And then there's a variety of ways of publicizing the study. If you're working with a school, you can have posters, set up posters. You can give talks to to an assembly. You can talk to the PTA. I've done that, when I've introduced studies. And usually that's part of the process of getting approval from the school. But it's also helpful to get parents involved and excited about the study. You can also talk to, church events, community fairs. You can do classroom presentations. You really need to judge what's most appropriate for your goals in your study. It's good to have a study website, and depending on how much interaction you're having with the students, particularly if you're doing like a longitudinal study, you may want to set up a Facebook page, and I'll mention that later. It's probably worth conducting, unless you have kids the same age, conducting student focus groups on recruiting and incentives, because they can sometimes tell you what is appealing, what the latest fad is, what might be, is it like a one of those plastic bracelets, or is it a Smurf or whatever, what might be an effective incentive for them to participate. And then for parents, if you're conducting a study where you're doing some sort of health screening, you can let them know that you're going to, if it's appropriate for your design, you can provide them with the screening results, which can be quite an incentive as well. And then I won't have time to go in much depth about this, but you need to consider sampling bias and response item bias. So take into account things like compliance and responsiveness. Measure your response bias at every level. Those schools you approached and those that refused. So if you can identify characteristics of the schools that refused and compare those characteristics to the characteristics of schools that participated, you can assess for response bias in the schools. You also want to be able to compare students who consented with those who didn't. And then you can also look at item response bias. If there's a survey and some of the items were not answered by a student, you want to see if there's characteristics of those students who didn't respond to those items. Some have suggested that in order to address response bias, you can assume that anybody who is missing from the study has the outcome, primary outcome, or has the primary risk factor, and analyze the data both with and without those outcomes in the sample, in the data set. And obviously, you can impute missing data when it comes to response items. And I'm not going to talk about retention. Retention is important, even if you don't think you're going to do a longitudinal study. I've had it happen that after conducting a cross-sectional study, the results were so interesting, we wanted to see if there were developmental changes. And so you want to be prepared to have enough information so that you can go back to the sample. And so you want a lot of information about how to contact the individual. Phone numbers and email addresses are usually best. And also get permission from the individual, the participant, child or parent, to be able to contact relatives and friends in case they move. And so you have their written permission to contact them about what their new address is. And there's a variety of other ways of tracking addresses. And the slide presentation had these, but I will not be able to have time to present those. So finally, the message is keep good records of your recruitment efforts and the results of each method. Monitor your retention and evaluate non-response bias at the school, student, and item level. Thank you.
Thank you, Ron, for an excellent presentation. I just wanted to remind everyone on the webinar right now that please enter your questions, and after the next presentation, we'll go through all the questions and present both the question and your name. Ron, I thought it was interesting. A lot of those points are really relevant and consistent with my experience as well. And so now I'd like to turn the webinar over to Suzanne Leland. And Suzanne, please begin.
Okay, thank you. Hello, everybody. So I am going to be speaking about the challenges of clinical trial research during pregnancy. So first, I'm going to talk about some of the reasons why it's important to conduct clinical trial research during pregnancy, and then talk about some of the challenges both in recruitment and retention and some strategies that have helped us overcome these challenges in recruitment and retention. And so my background is in obesity treatment and prevention, so that's a little bit of my slant that you'll pick up on throughout the presentation. So in 2009, the Institute of Medicine released guidelines for gestational weight gain during pregnancy, and these guidelines were designed to optimize maternal fetal outcomes, so such that normal weight women with a pre-pregnancy body weight in the normal weight range, were advised to gain up to 35 pounds during pregnancy, overweight women up to 25 pounds, and obese women up to 20 pounds during pregnancy. And unfortunately, many to most women exceed these recommendations for amount of gestational weight gain associated with the healthiest maternal child outcomes. 40% of normal weight women and 60% of overweight and obese women gain above these recommendations. And it's not perhaps surprising that there's a greater prevalence of exceeding these recommendations in overweight and obese women because the total recommended weight gain was lower than that for normal weight women. And exceeding gestational weight gains is associated with several adverse maternal neonatal child outcomes. Independent of maternal pre-pregnancy BMI, gaining above these recommendations is related to hypertension in mothers, preeclampsia, gestational diabetes, C-sections, preterm birth, and children who are born large for gestational age or with macrosomia. Excessive weight gain is also an independent long-term predictor of development of obesity in the offspring, which tracks through adulthood, and development of obesity in the mothers. So I think we can agree that interventions during pregnancy have the potential to improve the long-term health of both mothers and their offspring. Another reason to consider interventions during pregnancy is that pregnancy may be seen as a teachable moment for behavior change. And in this conceptualization, the teachable moment is when there's a cueing event, and so we're considering this to be pregnancy. And with this event, emotion is increased, the perceived risk and positive outcomes are increased. So in pregnancy, a woman's eating and activity not only affect her, but also her developing child. And pregnancy also has implications for mom's self-concept. Her role is maybe redefined as she's becoming a mom for the first time in some cases. And so these factors are thought to coalesce and lead to excuse me, enhanced motivation for behavior change, greater self-efficacy, and acquisition of skills that may lead to long-term adoption and success in this example with weight control behaviors. And the idea is if you time an intervention to occur during pregnancy or during a teachable moment, the effects of the intervention may be more long-lasting. So that's another reason to intervene. A final one I'll note is that pregnancy is a time when women are in contact with the healthcare setting, and childbearing women or women of childbearing age aren't frequently in contact with healthcare except during this period in life. And so it's an opportunity for us to intervene in both mothers and potentially their growing babies, and even you'll see in this picture there's a partner in the picture, and I would argue it's an opportunity to intervene to improve the health of partners also. So are we effective at intervening to reduce excessive gestational weight gain and improve the health of moms and the offspring? And this slide shows not a review of clinical trials in pregnancy, but a review of the reviews of intervention trials during pregnancy. So there have been a lot of studies looking at lifestyle interventions to improve the health behaviors of moms in pregnancy. But the conclusion of these reviews, for the most part, has been that the studies, there's inadequate study quality on which to base a definitive decision as to whether lifestyle interventions are effective or ineffective. And the limitations of existing research have included, one, there's a lack of randomized clinical trials in which to base our conclusions. That's actually been improved recently. There's been some clinical trials coming out, which have been nice to see. The interventions in pregnancy have been low intensity, and important for our discussion today, the current trials have had inadequate sample size and non-representative samples, which may have implications for recruitment. And there's a lack of long-term follow-up and poor participant retention in the study, which has implications for, well, study retention. So let's talk about the recruitment challenges and retention challenges and how we might overcome them. So first, the challenges to recruiting pregnant women. This is sort of from the perspective of a pregnant participant, and there are many practical barriers that pregnant women may face. They may have other work demands, child care demands, transportation issue, and privacy concerns. So these are the top barriers that we have observed and others have observed in recruiting pregnant women. The privacy concerns are usually linked up to the woman feeling that she has a unique medical condition during pregnancy, or she had complications during a prior pregnancy and she's worried about that being shared with others. But this is a time when women, I said earlier, it's an opportune time to intervene because the women are in contact with the healthcare practitioners, but we also have to realize that women are in a lot of contact with their providers. They are coming to frequent visits, and they have multiple blood tests, they have ultrasounds and maybe multiple ultrasounds occurring. They are encouraged to attend mommy and me classes and baby basics classes and preparing for childbirth classes and to tour the maternity ward. So all of these appointments could create added burden, and we have to be careful that we're not overwhelming women by adding our research on top of an already burdened schedule. The individual participant characteristics to consider is the women's attitudes and beliefs about research, which may vary. The women may not understand elements of research design, randomization, blinding. I remember observing one of our research assistants describing the studies to a pregnant woman, and she used the word, you'll be randomized to one of two conditions, and the research assistants will be blinded to that randomization, and you could just see the participants' eyes glaze over. So we need to pay attention to the language that we're using and adapt that based to the characteristics of the participant or the potential participant, and also understand the motivations for that the women may have for joining a research study. In pregnancy, the motivations differ from outside of pregnancy, and the motivations during pregnancy, women are more motivated to join the study if it's to reduce the risks of their baby, and that's more motivating to them than to reduce their own health risks. And as I mentioned to you earlier, being cognizant of the differences in the women's cultural background, language barriers, literacy barriers, and making sure the research assistants or recruiters are trained to adapt their language to the cultural and diverse characteristics of the women who are being recruited. There's some organizational barriers or factors that should be considered too in our recruitment plans. When you're recruiting pregnant women, you are sure to interact and need to be working collaboratively with prenatal care settings. And prenatal care settings have a group of practitioners from midwives and OBGYNs and nurse practitioners and nurses and dietitians and diabetes educators. There's a whole host of practitioners, and these practitioners are number one barrier to supporting research studies. There's a lack of time. They don't have time to include anything additional in their day. And the second barrier is concerns that participation will affect their relationship or restrict their ability to individualize their care with the pregnant women. So those concerns need to be addressed up front. Practitioners also voice concerns that the studied treatment or the assessments as part of the research project will be more aggressive than standard, and that should be clarified. I know in a study that we're doing right now, our protocol is to do a 75-gram oral glucose tolerance test during pregnancy to diagnose gestational diabetes. Well, we have some clinics who don't use the 75-gram test. They use the 50-gram test, and so we had to kind of negotiate that, and some clinics are willing to use our research method and some clinics are not. So you need to address those again up front and be cognizant of the organizational culture of each clinic. There will be varying degrees of support for research. We need to be clear about how our study will impinge or not on the use of space, and if the study needs to use space from time to time, we need to be very clear about how much, when, is there flexibility in that, and how that will be communicated. We need to be clear on whether there's any material or financial support that we can provide to the clinics for their participation and support of the study. Other barriers include contracts and, of course, getting ethical or IRB approvals, which can take a lot of time. I've had some contracts that have taken up to 9 months to get in place with different levels of review with hospital systems that may have very complicated review processes. So with that, let's talk about what strategies may be helpful to improve recruitment. And starting with the process and patient level factors, we use multiple methods of recruitment, including, as I mentioned, getting the prenatal clinic staff involved, encouraging women to bring their families to any research sessions or orientation sessions that we have. We give the patient pamphlets, but also do oral communication through the telephone, and also use mass media so that the study can be heard or known by a community. And I bolded there the face-to-face recruitment. That is what we have found to be most effective in reaching pregnant women. We have RAs who are housed in prenatal care clinics, and of course this is after having agreements set up with the clinics. And the RAs will sit in the waiting room at the time of women's first prenatal visits, and will give out brochures about our study to the women in the waiting room. And to respect patient confidentiality or a sense of privacy, we'll give pamphlets out to everybody in the waiting room, and with so one of our studies is recruiting only obese women, and we're testing interventions in pregnancy. Well, we don't say that, of course, in the waiting room to everybody. We say this is a study that's looking at lifestyle interventions to improve the health of pregnant moms. And we hand out the brochures, and any women who are interested, we ask them to fill out a consent to contact form, which they will fill out and provide to the research assistant, and then we'll call the women later and do the phone screen and answer any questions and give more details about the study. In some of our clinics, we don't do this waiting room recruitment. We have a space and set aside inside the clinic where the providers will bring the potential participants to us. So there's different ways to set this up. And we have to be sensitive to the timing of our approach. You know, if a woman may or may not be happy to have found out that she's pregnant. And so, again, close communication with the clinic staff is helpful here, where the secretary often will eyeball us a yes or a no, don't approach this woman. And we have to be sensitive to that and really be monitoring those types of communication. And I can't stress enough how important it is for the recruiters to have strong communication skills, to maybe be bilingual if necessary, and to maybe be from the same cultural background as the participants who are being recruited. It's important to make sure the patients understand, or the potential participants understand, the scope of their involvement, and to really make sure they understand this. You can do this in a lot of different ways. We're doing a study looking at meal replacements in pregnancy, and so we'll have the potential participants come in and try the meal replacements. You really want to kind of immerse them and make sure they understand what they're signing up for. And a concern that many women have in our studies and others have been that their involvement in the research might compromise or change their usual care, and so we really emphasize, make sure they understand that our programs are usually on top of what they would regularly receive and will not impinge upon that. Organizational level barriers we address with ongoing communication with our prenatal care clinics, with our recruitment clinics. We have newsletters that we send to the clinics on a regular basis to give them updates of progress in recruitment. We give incentives to the clinics for reaching various recruitment targets. Sometimes these incentives are tangible. We'll give them a fruit basket, and we'll give them tea, and I guess lots of food and beverages, but we also give them flowers from time to time. We will do lunch and learns, where an investigator will come and give a talk and also provide lunch to all the entire clinic team and staff. Sometimes, where appropriate, we have acknowledgments of our recruitment clinics and collaborators in publications or joint authorship, and it's also clinics like the potential advertising involved when we use mass media to advertise about the study. The extent to which you can have the prenatal providers give you input in all stages of the project, especially from the get-go, can ensure some buy-in that will help out later. And the extent to which you can make recruitment really easy for recruiters in the prenatal clinic if you are going about that approach. We also try to identify recruitment champions at each clinic where we're recruiting, and those champions are we found very helpful. We give them our brochures for the study and a script that's 2 sentences, just letting them know how they might approach describing the study and collecting our permission to contact cards. We share that with the recruitment champion, who shares that with their team, and we've really found that facilitates recruitment. But ideally, it's nice to be able to reduce the impact of the clinics by having a research-dedicated recruiter whose specific role is recruitment at the clinics. So you spend all this time and energy recruiting your sample. How do you keep the women in the study and our long-term follow-ups? And we've heard so many different reasons for participants not attending visits. Sorry, I can't today. My sister's friends, mothers, grandpas, brothers, grandsons, uncles' fish died. And yes, it was tragic. And you know, yesterday you said tomorrow. Well, today is tomorrow, and you're not here, and I've driven an hour and a half to do this visit, and you're not here. And so it can be very frustrating for research staff to promote retention, but there are ways around it to have high retention rates. And I think retention is very tied to recruitment. The more hurdles to recruitment or enrollment, the better the retention. So let me tell you what I mean. So some studies we've done a behavioral interview or a behavioral run-in where we require participants to write down all their food and beverages for a week and maybe their calories for a week, and we use that as sort of a measure of commitment and adherence. And the likelihood that they'll be able to engage in a long-term follow-up study. And that may work to increase retention, but it also may end up reducing diversity of your sample and excluding participants who may be those who need your treatment the most. They may have lower literacy and not be able to adhere to some of these behavioral run-ins. So consider the extent to which your inclusion or exclusion criteria may restrict your sample and how it's linked to retention. Some well-known predictors of greater attrition include higher depressive symptoms, smoking, low activity, obesity, dieting history, younger age, single and low SES, as well as patients reporting treatment dissatisfaction. So we consider these factors not as exclusion criteria, but just as a sign that patients who may have any of these factors, we may want to pay special attention to bond with them to ensure that they aren't going to drop out of the study. We use intensive follow-up and contact to increase retention. Ideally, we have the same research assistant who's recruited the participant conduct all the assessments until the end of the study to really, again, bond the participant to the specific RA and vice versa. The RAs keep a detailed tracking and notes page where in our tracking system where we can remember if the participant shared that their grandmother had a special birthday or a special event, that we will take note of that and ask them how the event was at the follow-up, and again to keep this kind of personalization going. We'll send thank you notes, and when they have their baby we send them delivery, congratulation cards, and small gifts. We send birthday cards that are personalized and signed by all investigators if possible. We send the participants newsletters every 2 months, just giving them study updates. We as well collect multiple family and friend contacts. We collect greater than 6 at enrollment, and we update these phone numbers at all the follow-ups, and that's critical, has been critical to our retention efforts. We do 10 attempts to contact participants, and and this is only if participants don't call back. So you don't want to, of course, overly annoy and burden the participant with your phone calls, but we are persistent in attempting to reach out to the women for follow-up assessments. Our team has to be flexible with dates and times of the assessments. We have a toll-free study number, so participants don't have to pay for calling us. We will provide babysitting. We'll try to conduct the assessments at the time of their women's regularly scheduled prenatal visits so as to reduce the number of meetings that they will have. We pay for travel via or bus, and we also conduct home visits. And this is sort of as a last strategy because it is quite costly, but it is in working with pregnant moms and moms with young children in the homes, we find that it is necessary to do home visits. And I've had research assistants obtain a women's weight measure in parking lots. So we will go to the women to obtain our primary outcome. And along those lines, we have a tiered level of assessment. So we have the full assessment battery, but then in women who have been hard to reach and hard to schedule, we have shortened versions of our assessment packets. We will do interview questions over the phone, and we triage such that we collect the most important data first for our primary outcome, followed by the other secondary outcome data. And incentives, of course, are a part of an effective retention plan. Providing them at the time of their visit is optimal. So I'll just briefly talk about some potential barriers to interventions during pregnancy. I won't have time to go through this, but just to point out, in this cartoon there's an older woman saying, "How is pregnancy going, dearie?" And the pregnant woman says, "Oh, just fine." But in her head she's saying, if I could just ignore the backache, constipation, heartburn, nausea, vomiting, acne, aching feet, incontinence, exhaustion, varicose veins, stretch marks, moodiness, and the nosy strangers. And actually this list could go on. If it was a complicated pregnancy, she could add, and my glucose testing and my insulin shots. And so it's just to make the point that pregnancy throws a woman's all her whole system into whack. And so our interventions have to be layered upon this to really consider these factors. I mean, women's have cravings, 70% experience nausea and vomiting. These have implications for our diet and exercise interventions that we test. And so the extent to which we can tailor our interventions to meet these specific pregnancy factors, the better. So to conclude, there is a strong need for well-designed trials testing lifestyle interventions during pregnancy. Long-term maternal and offspring follow-ups are needed in the literature. Using strong recruitment intention plans will facilitate will improve upon some of the limitations in the literature to date, including having a plan to bond the participant to the study, involve recruitment clinics, and use flexible assessment methods. And I'll just add one more point here. Are we missing the boat? Here's a man who's focusing on one direction, and behind him is a bird, I guess a penguin, saying, "Should I tell him I am here?" And oftentimes I worry that are we focusing too much on intervening during pregnancy while ignoring other times, in particular the pre-pregnancy period. So pregnancy is kind of part of a cycle of women get pregnant, and then there's this postpartum period and an interconception period and the pre-pregnancy period, and there are risks that could benefit from intervention during this postpartum, pre-pregnancy intervention, that I think that we have to start conceptualizing pregnancy intervention as this whole time period, and to start to conduct research that looks at pregnancy both before, between, and beyond pregnancy. And that's it. Thank you.
Thank you, Suzanne. That was a really interesting presentation and brought up a lot of the concerns I think that those of us that have done work in this with this population have. So I really enjoyed that.
Great.
So right now we have some time for questions, and so if anybody in the audience would like to go ahead and ask a question in the chat box, and we'll respond to them. So I think what I'll do is there's a few questions here, and I have some as well. So we will start maybe, Ron, with you, and then we'll go back and forth, if it's okay.
Sounds good.
Okay. So I have a question from Rick Prince, who says that when he did research in schools, the region in which he did his research had 4 or 5 universities approaching the children. Some researchers indeed did not give the reports, or et cetera, and as a consequence, the staff was increasingly anti-research. And on a policy level then, there was a research ban for the entire region, so they weren't allowed to do research in schools for 6 months. Mm. So how do you deal with this negative image research may have when recruiting schools?
Yeah, that's a good point. And the message also is that as a researcher, if you're working with the schools, you really have an obligation to provide them feedback, not just for you, but for all the other researchers who would like to conduct research in schools. Well, I think there's a couple of things. I mentioned in the beginning, really trying to find out what the school wants. So there may be things that are tangential to your research that you could provide them. So that's one of the approaches, is trying to be more collaborative with the school and see if there are things that you could do. And it may not necessarily mean something that you do with your research, but services you can provide, as I mentioned, talking in an assembly, working with teachers who might be trying to develop curricula, those kinds of things, so that the school perceives it not as that you're using them and using their time, but rather that you have a real interest in the children and the teachers, and that you're going to collaborate with them, not only on your research, but on things that they may need that you could provide.
So, Ron, in a situation like this, would you even think that it might be worth it to speak to the individual schools at all, or would you probably wait until the 6 months was done? I'm just curious.
Yeah, I have a colleague who's really good at what she calls converting the schools. So when we get a no, the school doesn't want to participate, she does approach them to find out why and what we might do. And as I said, if you approach them not just with the idea that you want to do this study, but that you're going to work with them, that 6 months, they may have something more urgent that they'd like done, and so that may give you an entree into the school.
Yeah, I thought that was interesting because we've actually done that too before, converting them. So not
the other
always
thing, and I've never done this, but I don't know if you've done it, is if you can find out who did the other research, maybe you can get them to finally provide a final report and use that as your entree into the school.
Yeah, that's a really good suggestion. One note I might want to make to the audience is we are able to open the microphone, so if someone else wants to ask a question, please feel free to chime in. Right now I'll ask Suzanne a question, and then maybe if someone else wants to chime in, and I have some other questions as well. So Suzanne, I have a question from Rick for you. Do the various methods you use reach different groups of patients, and maybe explain that a little bit more?
So in the pregnancy studies we have done to date, we have recruited, in our population in Central California, 60% Latina women and 45% of whom are low income on average. And some of our studies we recruit solely through WIC, the Women, Infants, Children Supplemental Nutrition Program, and so all of those women would be low income. So our approaches are designed to reach women who often come from diverse backgrounds, low income, and often low literacy. But amidst that, we have women who are highly educated, PhD pregnant women joining our study. So I think our approach to recruitment is the same in terms of going to the clinics and meeting these women face to face, but we work with recruiters and our research assistants to be attuned to the individual patients who they're working with, they're recruiting, and to adapt their language and their demeanor and their explanations accordingly. Did that answer the question?
Yes, that makes a lot of sense. Go ahead.
So this is Rick. If you want to ask a question in person, you can raise your hand, your virtual hand, obviously in the control panel. So if you raise your hand, then we can give you the microphone if you want to. Yeah, that's what I want to say.
Thank you. So Rick has another question for Ron. So, and this has actually come up in our research as well, so I'm eager to see how you answer this. If you do intervention research in a classroom, so say you're doing a computerized intervention or something like that, and there are pupils that there are children in the classroom who are not consented to participate in the research, how do you deal with those children? Officially, they should be out of the research and the intervention, but sometimes you can't. If you pull them out, you might add a stigma to them, and it might be that there's certain kinds of kids who are not consented. So how do you deal with that? And it might be that they're still in the same classroom, so you can't necessarily pull them out as well. So there's several different situations that arise.
Yeah, that's a really good question. So I don't have a great answer. One of the things we've tried to do is, much as what Suzanne was talking about in recruiting, not trying to exclude anybody. So some possibilities, I would say, is if the program you're providing is in a school setting, it's considered educational, and if the teacher has reviewed it and agrees it would be something that all the children should experience, then you might be able to then present the intervention, just not do the assessment. so that they would not be involved in any assessment in the study, but they would receive, because it's an educational intervention. In fact, most IRBs would say if it's part of the school curriculum, you don't even need permission to do it. So that's one possibility. If it's something that's a bit too experimental, and there would be some concern that there might be emotional, if something about I don't know, prejudice or something, and usually the kids would not be part of that, then I think you try and work with the teacher to find an alternative activity, and you might even say, okay, now we're going to break up into 2 groups, and just not mention, act as though it's just the normal division of the classroom. But then, of course, you'd have to have another space for those students who are not participating. Those are my best ideas, anyway.
Yeah,
Deanna,
actually,
yeah.
Oh, I was going to say we have provided activities. So sometimes, especially if it's intervention that isn't too long in the classroom, we'll provide maybe a word puzzle or something that's developmentally appropriate for the kids to do. So exactly what you mentioned.
Yeah.
Okay, Suzanne, I have a question for you from Tanya Nansel. Have you conducted web-based assessments, and if so, what methods have you found to facilitate completion?
So that's a great question. We have conducted web-based assessments, and the research would suggest that the validity of web-based versus paper assessments are comparable. So that's always comforting to me. But the web-based assessments, we've offered both and given participants the choice. But often with our population, not all of the women are guaranteed to have access to a computer and or a computer with internet access. Many to most have mobile phones and could certainly go to a library to use a computer, but we don't want to add any barriers. So for the most part of our research with the populations we're working with, we have used paper questionnaires that scannable forms that we then go on to scan. In the web-based assessments that we do use, we'll go into the clinics with iPads or tablets and have the patients complete the assessments in the clinics. But that can take time because a lot of our questionnaires are extensive. So, but we'll do some key measures in the clinic using our notepads, or we'll email them links and they can go on to complete the assessments at home. And my preference would be to move towards web-based assessments because you can have greater controls in place if they fill in an incorrect value, and so that's my preference, but I don't think we're quite there yet in working with underserved populations. But my prediction would be in the future that that will be the way to go and will be accessible to most of all of our participants, even those who may be underserved.
Yes, I really have to agree with you on that. You know, whereas we would definitely prefer a lot of times the web-based entry, a lot of times in our population, just as you mentioned, they might have a smartphone, but they don't necessarily have access to a computer.
Yeah.
So unless you provide one, like you mentioned, it's difficult to incorporate that. Great. I just wanted to take a second and see if anyone from the audience had a question. Please fill in the chat box, or you can raise your hand as well. But I actually had a question, and this one is actually for both of you, Ron and Suzanne. I know when we apply through our institutional review board for doing human subject research, both with children and pregnant women, it's considered a population of that you need to take extra care with. So we have to have an additional review of our IRB procedures, our human subjects procedures. So I just wanted to know, have y'all encountered the same thing? You usually have to bring someone else in that's an expert in child, that's an expert in child research or pregnancy research. Have y'all found the same?
I can go first, Suzanne. Yes. And I found that my IRB protocols that involve pregnant women or children take much longer to finally get full approval for than working with other populations, as maybe perhaps they should. But it's a challenge. I mean, we have a protocol that's under review right now where we are proposing to put accelerometers on toddlers to measure their physical activity and sleep. And a concern was raised that, well, we're using waist-worn accelerometers, and there was concern that the belt could be moved and potentially lead to strangulation of the child. It was actually written as a concern. And so I think the IRB reviews are very, again, as they probably should be, very, very sensitive in thinking of all possible risks, and that we need to address in our research. So I think it's translating in terms of into conducting the research, it just takes longer to get approval sometime for these protocols, and you may have to be more flexible.
And this is Ron. I haven't had that experience. So the most recent research I conducted was sort of family-based research, and it was at UMass Boston, and that was never raised. In fact, and we are having the children wear accelerometers around their waist, and they're very young, actually. And then prior to that, I was at the National Institute of Child Health and Human Development, and so the entire IRB was filled with experts. But the very different thing, and I don't know if this happens in other places, is they really expect the investigator to come and speak with the board and answer questions. So they had the opportunity, and they did question about procedures while I was there. But as I said, it was NICHD, so they were all experts in the area.
Great. So I have another question for both panelists from Leah, and the question is, she'd love to hear from both of y'all about what communication strategies work best during a study to maintain contact and encourage protocol adherence by participants. Sorry. I would guess this might be quite different for pregnant women versus children attending school. Would y'all like to comment on that?
Okay, well, this is Ron. One of the things we found useful when we were conducting surveys in the schools is to have our own research assistants conducting the survey. Teachers can stay in the room for disciplinary reasons, but to make sure that there was a uniform presentation of everything, we had research assistants from around the country, actually, that we flew into Washington and trained them to follow the procedures pretty precisely. And if they couldn't, we didn't hire them. So that was one thing we did. And then in terms of interventions, yeah, that's a good question. We did have considerable variability. I guess the intention to treat becomes really important. Considerable variability in how families and children adhered to the protocol. You just need to monitor that and make sure you're measuring it so you can take that into account. That was my approach.
And I'll just add to that, what we found works best is text messaging. And we will call and leave messages and send emails and snail mail letters and get nothing. And then the women will respond to a text message. So with that is our go-to tool, and we want to be careful not to overutilize it. But we will do text messages, and we incorporated that into some of our interventions as well, because that can be certainly a motivational and effective tool. So we have that in some of our intervention protocols, but do use it, of course, as a retention strategy. And also what will happen is phone numbers will go in and out of service in the population that we use. So even if we can't leave a message, or the phone's disconnected, or the text messaging isn't going through, we can wait a couple weeks and the phone will be turned on again because they receive some financial support. And so that if it's out once, don't throw away the number. It may be activated again later.
That's interesting, because we found that same thing in our populations. The text messages have been extremely effective in that, keeping in contact with the participants. So I was just wondering if there are any final questions. If not, I would like to thank the presenters, and there's contact information there, and turn it over to Rick Prinz.
Thank you, Deanna.
Thank you. So thank you all for coming here, for listening. Thank you, Ron, Suzanne, and Diana for running the webinar, and thank you to Tonya and Leah for organizing this for us. So I want to say to you, well, there is another webinar in a few hours on early care and education if you can't get enough of this all. It's on the economics of early child care and education based obesity prevention. And one final remark is that if we close the webinar in a minute, then a small survey will pop up, and that we would really like you to just spend 2 minutes on that, so we can actually evaluate, do some process evaluation, as we like to do, to see how well the webinars in general are appreciated. So that was it. Thank you all. Thank you for listening, and hopefully see you soon. So I'm going to close the webinar now.
Bye-bye.
Thank you.
Bye-bye.
Bye.